for frozen section that you all must be using. This is basically a box and you just put the specimen inside, you stain it with acridine orange, and you can see the entire sections both horizontally as well as vertically. So you're not leaving it to the bias of the pathologist to choose an area where they feel that this is suspicious and then sample that. This imaging technique samples the entire block of tissue that you're submitting. Since we have a lot of tumors which are borderline resectable, they are large, they don't really offer much survival advantage performing surgery in them. So we wanted to see whether neoadjuvant chemotherapy really adds any advantage. And this is much after most of the papers by Zong et al. As well as Lisa Lecitra. Much of their work has been the basis for our neoadjuvant trials. We've developed our own indications for borderline resectable because this is often debated. Tumors reaching up to the zygoma, tumors reaching large skin involvement, tumors reaching the vallecula, where you might need a laryngectomy, as well as tumors which are near the hyoid. So based on this, a few years, almost 10 years back, we did a randomized trial. This had almost 700 patients, and we recently published our paper of real-world evidence of 3,200 patients that underwent neoadjuvant chemotherapy. This definitely, for borderline resectable, is a great option because it allows you to chemo-select the patients which are going to perform much better than the ones that might not do so well even after completion of the conventional therapy. Now, immunotherapy is growing. Keynote 689 has shown a definite advantage for use of pembrolizumab in the resectable setting. But as you know, our country doesn't have a lot of resources. Our patients do not come from with a lot of resources. Insurance is very difficult. So we try to do a low-cost version of nivolumab, which is half dose, 40 milligrams per meter square now, and as well as oral metronomic chemotherapy, that is methotrexate, celecoxib, as well as erlotinib. This was in a recurrent metastatic setting, and this was published in the JCO. It's definitely shown a great survival advantage in that group. And now we're doing a phase 3 randomized trial to compare these two in the neoadjuvant setting as well. Now, can a blood test actually be used to diagnose and prognosticate circulating tumor cells? This is something that we are also using and trying to understand in our setting. Squamous cell carcinoma of the head